This section of neuroscience deals with the clinical neurology of the basal ganglia. The basal ganglia, like the cerebellum, play a role in certain aspects of motor movement. Functionally, the basal ganglia, their major job is to get movement started. So we say on this slide under general features, they initiate and in a way provide some gross control over skeletal muscle movements. So we can kind of argue that the basal ganglia and the cerebellum work in tandem, whereas the basal ganglia gets movement started. Once the movements are initiated by the basal ganglia, the cerebellum takes over and makes sure the movements are executed smoothly. Now, as we saw when we talked about the cerebellum, all of the cerebellar structures were found in one secondary brain vesicle. They were all localized in the metencephalon. In contrast, the basal ganglia are spread over three very different regions of the central nervous system. Most of the major basal ganglia structures are subtelencephalic, meaning that they are found at the base of a corresponding hemisphere. And there are four basal ganglia components that are subtelencephalic. Two of them comprise the striatum. The striatum consists, as we say here, of the caudate nucleus and the putamen. These two regions are histologically and functionally similar, but they are separated at the base of each hemisphere by the fibers of the anterior limb and the internal capsule. The other subtelencephalic basal ganglia components are the two segments of the globus pallidus, the external and the internal segment, both of which lie medial to the putamen and therefore lateral to the internal capsule. Two other major basal ganglia structures are found outside the telencephalon. They are the substantia nigra, which is a major nucleus in the midbrain of the brainstem, and the subthalamic nucleus, which, since it ends in the word thalamus, must be in the diencephalon. So, at the outset, the basal ganglia structures are much more widespread than the cerebellar structures, so meaning that the connections between them have to be widespread as well. The next point is, how do the basal ganglia work? Well, with regard to the cerebellum, we saw that cerebellar input came from a variety of locations, some of it from motor cortex, a lot of it from the spinal cord, vestibular system, and the olive, and so on. Virtually all of the driving force that generates basal ganglia function is coming from motor cortex, as well as other areas of cortex. So virtually all of the input to basal ganglia structures are coming from a cortical location. Then, what characterizes the basal ganglia are two parallel but slightly antagonistic basal ganglia pathways that flow through the basal ganglia, driven by cortex, and project back to motor cortex. So these two parallel basal ganglia circuits are known as the direct and the indirect basal ganglia pathway. Both of them are driven by cortex. They relay back through one of the motor nuclei of the thalamus and then project back to motor cortex. And as we'll see, one of these pathways will generally function to get movement started, to initiate skeletal muscle movements. The other pathway, it's thought, functions to suppress unwanted movement in favor of the desired movement. Now, an additional feature that's common to both pathways is that both pathways will contain two inhibitory neurons in a row in them. And as such, since there are two inhibitory neurons in series, both pathways will utilize a phenomenon known as disinhibition, where one inhibitory neuron inhibits the second inhibitory neuron, but the net effect is a net excitation of the next neuron past the two inhibitory neurons. So both pathways will be characterized by two inhibitory neurons, GABA neurons, creating a disinhibition of a third neuron, which result in its net excitation. So the classic diagram that illustrates the connections and the players in the two basal ganglia pathways is illustrated on this slide. And you can see at the top of the slide that running vertically are the components of the direct pathway, and beginning horizontally are the components that comprise the indirect pathway. So let's do the direct pathway first and illustrate basically by its neural connections and the neurotransmitters in the pathway, what its effect will be on motor cortex. Again, some similarity. Both basal ganglia pathways begin with cortical excitation of neurons in the striatum, neurons that are located in either the caudate nucleus or the putamen. So the direct pathway begins as such with cortical excitation of a specific population of GABA neurons in the striatum, specific in the sense that they are also co-localized and utilize substance P as a co-transmitter. So the direct pathway begins with cortical excitation of a population of GABA neurons in the striatum. Those GABA neurons project out of the striatum and project mainly to the internal segment of the globus pallidus, where there is a second population of GABA neurons. So the disinhibition in the direct pathway is formed by GABA neurons in the striatum that synapse with GABA neurons in the internal segment of the globus pallidus. The point is that the next neuron past the two GABA neurons is going to be excited by the disinhibition. And the next neuron in the direct pathway is a neuron that's in the motor nuclei of the thalamus. So in essence, the motor nuclei of the thalamus are excited by the direct basal ganglia pathway, and that thalamic neuron in turn projects back to motor cortex, excites motor cortex, and promotes the initiation of movement. So in a word, we can say, in summary, we can say that the basic function of the direct basal ganglia pathway is to drive the motor cortex and promote the initiation of movement. Now, let's do the same for the indirect pathway. The indirect pathway also begins with cortical excitation of striatal neurons, but the striatal neurons that begin the indirect pathway are a different population of GABA neurons that are co-localized with enkephalin as a co-neurotransmitter. So, cortical excitation drives the indirect basal ganglia pathway GABA neurons, but look where they project. They project to the globus pallidus external segment, where again we find a second population of GABA neurons. So the disinhibition in the indirect pathway is formed by striatal GABA neurons and external segment GABA neurons. Next point is the neuron past the disinhibition in the indirect pathway are neurons in the subthalamic nucleus. So subthalamic nucleus neurons are excited by the disinhibition in the indirect pathway, but they too are excitatory. So the indirect pathway excites the subthalamic neurons, but they project back to the globus pallidus internal segment. And they excite the single population of GABA neurons that's found there, such that the net effect of the indirect pathway is the GABA neurons in the internal segment suppress the activity of the motor nuclei of the thalamus and function to suppress unwanted movement in favor of the desired movement. So in summary, we can say that the direct pathway drives the motor cortex, promoting the initiation of a desired movement. The indirect pathway mainly functions to suppress unwanted movement. Next, in addition to the GABA neurons that we see in both pathways, as well as the glutamate neurons that are in both pathways, there are two other important neurochemically specific neurons that play a role in basal ganglia function. One of them is dopamine, that's basically produced and synthesized by the dopaminergic neurons in the substantia nigra. The other are cholinergic neurons, which are found only in the striatum. And the point is, these two neurochemically specific neurons have different effects. The dopaminergic neurons basically drive or excite the direct basal ganglia pathway by projecting back to GABA neurons and exciting those GABA neurons in the direct pathway, mediating their effects through excitatory D1 receptors on the direct pathway GABA neurons. The dopaminergic neurons basically suppress the activity of the indirect pathway by binding with inhibitory D2 receptors that are on the indirect pathway GABA neurons. So the effect of dopamine enhances the direct basal ganglia pathway. In contrast, the cholinergic neurons, which are intrinsic to the striatum, have the opposite effect. they tend to excite the indirect pathway, decreasing cortical excitation and obviously enhancing the indirect pathway's effect to suppress unwanted movement. So the two additional neurotransmitters have effects specific to a direct basal ganglia pathway. Dopaminergic neurons drive the direct pathway, cholinergic neurons drive the indirect basal ganglia pathway, respectively. Our next point is, what kind of diseases do we see associated with the basal ganglia? And fundamentally, basal ganglia disease usually is associated with one or the other pathway. So the first one that's presented on this slide is Parkinson's disease. That is a classic direct basal ganglia pathway lesion, classically caused by a loss of dopaminergic neurons, usually bilaterally, because it's a degenerative phenomenon in the substantia nigra. So the causes of Parkinson's disease may be infections, vascular insults, may be idiopathic. They may be caused by side effects of what are called designer drugs. But since it is a direct basal ganglia pathway disease caused by the loss of dopaminergic input, now motor cortex is underactive because we now have an overactive indirect basal ganglia pathway. So classically, regardless of what pathway is lesion, the hallmark of a patient with basal ganglia disease is these patients will present with tremor at rest, an involuntary tremor, in contrast to patients with cerebellar disease that only exhibit a tremor with an intended movement. But certainly, depending on which pathway is affected, there are going to be different forms of the tremor. In a patient with Parkinson's disease, since we have an underactive motor cortex caused by the loss of dopamine, these patients have all the signs and symptoms of rigidity. They have poverty of movement, what is known as a cogwheel or ratcheting rigidity. Their pill-rolling tremor is the classic rigidity-based tremor, as if you're rolling a pill in the distal part of your fingers. These patients shuffle when they walk. They chase the center of gravity. They have a stooped posture, and they have a masked facial expression because all of their skeletal muscles bilaterally are underactive, caused by a direct basal ganglia pathway lesion. In contrast, one of the hallmark diseases of the basal ganglia that involves the indirect basal ganglia pathway is Huntington's disease. This is an autosomal dominant problem that affects chromosome 4, but here the degeneration occurs in GABA neurons, mainly in the indirect pathway, that are located mainly in the head of the caudate nucleus, not so much in the putamen, head of the caudate nucleus, GABA neurons in the indirect pathway. But now the problem is kind of the opposite one. Instead of having an underactive motor cortex, since this is an indirect basal ganglia lesion, now we have an overactive motor cortex. And in this particular condition, we see a wide variety of bilateral overactive movements manifesting themselves in the dance-like bilateral movements that characterize Huntington's chorea. So frequently, patients with Huntington's chorea with the dance-like involuntary movements, particularly of the upper limbs, progress to athetosis, which are writhing limb movements that are usually superimposed on the choreiform movements. So certainly one of the treatments of this patient is to give them antipsychotics to suppress the dopaminergic influence on the direct basal ganglia pathway, because now we have an overactive motor cortex and we want to reduce its activity respectively. So that's a classic indirect basal ganglia pathway disease, Huntington's disease. Next, Hemiblismus is caused by, usually is seen in a hypertensive patient, is caused by what's known as a lacunar infarct of one subthalamic nucleus. And since we know that the subthalamic nucleus is a very important indirect basal ganglia structure, this is another example of an indirect basal ganglia disease where the patient presents with wild flinging hemiballistic movements of the upper and lower limb contralateral to the lesion subthalamic nucleus. So this is a unilateral problem. And as we'll see, since all the basal ganglia connections are associated with an ipsilateral hemisphere, if you lesion an isolated basal ganglia structure, the effects of that lesion will be expressed contralaterally versus a unilateral lesion of cerebellum, which resulted in an ipsilateral motor problem. So patients that develop Tourette syndrome is also associated with an indirect basal ganglia phenomenon. It's commonly associated with basal ganglia problems in patients that have obsessive compulsive disorder or ADHD. And again, the treatment, like patients with Huntington's disease, can be mediated by antipsychotic agents. Finally, Wilson's disease is, as we well know, a defect in copper metabolism, where there's an accumulation of copper in the liver and the central nervous system and in the Kaiser-Fleischer ring that basically lines or is a classic landmark of this disease in the cornea. So again, this is a combination of lesions not only in the basal ganglia, it can also involve cerebellar problems, but the classic kind of tremor you see in this patient is a wing beating tremor that's generated by the upper limb when they're attempting to perform a motor task. So wing beating tremor is a classic sign associated with Wilson's disease, but it's hard to determine whether this patient is actually, the wing beating tremor is actually associated with basal ganglia dysfunction and or cerebellar dysfunction, because they're both involved presumably in the Wilson disease patient. Finally, it's very important to be able to localize in a horizontal brain section where various basal ganglia structures are, what their relationship is to one another, and how they're positioned relative to the fibers of the internal capsule and to the components of the diencephalon. So a horizontal section basically is the best way to visualize basal ganglia structures, as well as the entire extent of the anterior limb, posterior limb, and the geniole of the internal capsule. So note that most of the basal ganglia are situated lateral to the limbs of the internal capsule, specifically including the putamen and medial to the putamen, both of the segments of the globus pallidus. But note that the head of the caudate nucleus is situated medial to the anterior limb of the internal capsule, even though it's histologically similar in function and in terms of neuronal cell types to the putamen. But don't confuse the location of the head of the caudate nucleus, which is medial to the anterior limb of the internal capsule, from the larger thalamus, which is medial to the posterior limb of the internal capsule. So it's not uncommon for exams to show basically MRIs of various brain sections and describe a patient with a certain neurological disease and ask you where there might be neuronal degeneration, neuronal loss, atrophy, or the problem, based on a second or third order question, assuming that you can identify various brain components in an imaging question rather than just knowing what the answer is in a multiple choice question. So again, just as an example of this, the next picture shows a horizontal MRI, basically at about the same level. And again, the key element to identify is the V-shaped internal capsule that's labeled C and D on here. Specifically, C is the geniole of the internal capsule, D is the posterior limb of the internal capsule in this T1 weighted MRI. And note the identity of the structures that are found medial and lateral to the internal capsule. B is the head of the caudate nucleus, that's situated medial to the anterior limb of the internal capsule. G is the putamen, it's located lateral to both limbs and the geniole of the internal capsule. The slightly darker shaded area medial to G represents the location of the segments of the globus pallidus. And finally, medial to the posterior limb of the internal capsule is the rounded profile that constitutes A, that's the thalamus, the major part of the diencephalon. And just for completeness, E is primary visual cortex, so on the medial aspect of each occipital lobe, and H and I are probably language centers, assuming that that's the lateral aspect of the left hemisphere. And finally, over on the left margin, we again make the point that unlike the cerebellum, all the connections of the basal ganglia, meaning the connections of B and G, are with the hemisphere on the same side, meaning that the cortical input to the basal ganglia labeled B and G is coming from this hemisphere. These basal ganglia structures project back to motor nuclei of the thalamus at A, and then A projects back to the corresponding hemisphere, all of the connections being ipsilateral.